Greetings everyone. Please can I get a show of hands on the chat that the sound is coming through clearly? Can everybody hear?
How did you go down to the chat box? Maybe a bit of setup to the admin, just a bit of admin before we start. Good morning, everybody. Welcome to the NIOH session. Can I just advise you at the bottom of your Zoom screen, there is a chat bubble. If you click on the chat bubble, your chat box will come up, and we would like you to indicate if you are getting audio and video.
We're getting an indication that there is audio, so.
If somebody says that you can't hear properly, please check if your speaker is on. Right? Your speaker is on. I hope the person could hear that.
Thank you, everyone. A very warm welcome to you from the National Health Laboratory Service, the NHLS for short, and the National Institute for Occupational Health, the NIOH for short. As many of you may know, the NHLS provides a diagnostic service to 80% of the South African population, and the NIOH promotes healthy, safe, and sustainable workplaces. My name is Tanusha Singh, and I'm leading the Occupational Health Response Team at the NIOH. And the team has put together a series of information and training sessions on COVID-19. And one of those sessions today is focusing on dentists and our general practitioners. We know that you encounter a number of challenges being in the front line, and we'd like to extend a warm thank you to you for the extraordinary measures that you are taking whilst providing an essential service to the nation. We'd like to ask you to please exercise some patience because some of the information on the update of COVID may be known to many of you, but there may be some participants that do not have the information. And just a few announcements. Please could you kindly register on the chat your name and your email address so that we can share some relevant information from the session. And also just to know that during the session you will be muted. And so it would be important for you to raise any questions through the Q&A box or the chat box. And at the end of the session, we will have a panel to address these questions. And should we run out of time, we will endeavor to make the answers available to you via the NIOH website or also via the email. With that, I'd like to thank you and hand you over to our program director, Mr. Ashraf Raycliffe.
Thank you very much. So welcome again to the National Institute for Occupational Health online Zoom COVID-19 training session. And today we have a specific target group, an occupational group, and that's the general practitioners, probably mostly in community service provision, as well as dentists, all categories of dentists, general practitioners, and probably specialists as well. We welcome you to, I'm not sure if this is our 10th session, and probably today we are going to hit a record number of probably close to our maximum of 500 logins on our current Zoom platform. So welcome to our COVID-19 workplace preparedness training, and I think I've got Thursday's program, apologies. My apologies for that. So the COVID-19 preparing for GP and dentist practices on issues of health and safety. And we have colleagues working here at the National Institute for Occupational Health in our various sections: occupational medicine, occupational hygiene, immunology, and microbiology. Yeah, thank you. And then many other colleagues that we rely on to assist. The person who just welcomed you, Dr. Tanusha Singh, is also the chairperson of our COVID-19 outbreak response team, addressing workplace preparedness and prevention in all occupational settings and practically for all sectors of the economy. So I'm now going to introduce our first presenter, and that's Dr. Odette Valming from the Occupational medicine section of the NIOH. Please join me. And then to remind you, while she's joining us, at the bottom, for those who just joined us, please type, there's a chat bubble at the bottom of your Zoom screen. Click that, your chat box will pop up. Please type name, surname, your email address for future communication and for the presentations we're doing today and other resources to be communicated to you, and for future invitations to occupational health sessions that we may run in the future as the NIOH. And then that very same chat box, as Dr. Singh indicated earlier, Tanusha said, please type your questions as the presenters are busy in that chat box. We will then, in our sort of panel session towards the end, after all the presentations, address the questions, as many as we can, in the time that we've got allocated. I now hand over to Dr. Mohamed.
Thank you very much. Hi, good day. Good day, everybody. Thank you for being here. Thank you for the service that you're doing in the communities. Today we're going to be speaking to mostly the dentists and the general practitioners. And initially I'm going to be speaking about COVID-19. Just to give you an update, I'm sure there's a lot of information you already know, so please bear with me. Sorry, 1 second, we're just going to get the slides up. So because of the constant changing information that we are seeing, as research is going on, there's just constant updates, constant new information coming out. So this is a slide just for you to see where you can get up-to-date information. The NHS website, the NIOH and NICD websites, as well as the National Department of Health websites. WHO is a good resource to use for also updates and guidance. Okay, just moving along. Okay, so by way of background, on the 31st of December 2019, the WHO China saw a cluster of pneumonia cases in Wuhan. And by the 7th of January 2020, the causative pathogen was isolated and it was identified as a new or novel coronavirus, which they gave the name now, SARS coronavirus 2. By the 13th of January, the virus first appeared outside of China's borders. And then on the 13th of January, the WHO declared a public health emergency of international concern. And sadly, on the 5th of March 2020, the first case of COVID-19 was confirmed in South Africa. On the 11th of March, a pandemic was declared by the WHO, and on the 16th of March, President Cyril Ramaphosa declared a state of disaster. And then on March 20, the 23rd of March 2020, the President declared that there would be a 21-day lockdown in South Africa. Okay, so currently, in terms of the stats of yesterday, the global burden of COVID-19, there's about 715,000 confirmed cases and more than 33,000 deaths. And if you can see from the map, is that there's a very few countries that are not affected. With regards to South Africa, we've conducted more than 35,000 tests, and of that, there were 1,326 positive cases identified and 2 deaths. There has been talk about that there's a little bit of bias with regards to the selection of people being tested, and so it could be an underestimation of the burden of disease in South Africa. And just of note is that there are 13 healthcare workers that are already infected nationally. So here's the importance of doing this training and our frontline staff being able to protect themselves. So in terms of the microbiology and epidemiology, it is an enveloped, single-stranded RNA virus, and it's covered with sort of club-shaped glycoproteins which look like crowns, and hence the name coronavirus. And there's more than 40 species of this virus. And a lot of them have been around for a long time and are responsible for the common cold or self-limiting upper respiratory tract infections. Okay. So coronaviruses have been known to cause diseases in not only mammals and birds and humans, and there have been some cases where there has been a crossover from a virus that initially was only transmitted in animals going into humans. And in 2002, 2003, we had a global outbreak of SARS, which spread to 37 countries within 2 weeks and had more than about 8,000 cases and accounted for more than 700 deaths. And then later in 2012, we had the MERS coronavirus, which had just under 3,000 confirmed cases and accounted for more than 800 deaths. And this was located in the Middle East, but also detected in about 17 other countries. Okay. So how does it spread? I know there's a lot of talk in the media about spread. And, you know, it's spread via respiratory droplets, which often come from an infected person who's coughing and sneezing. These droplets, as you can see in the picture, can travel up to 2 meters. So it's mainly by droplet spread. And these droplets can also, just to go back a little bit, they can either come in the breathing zone of the person who is standing less than 2 meters away and be inhaled, or they can, if somebody touches surfaces where the droplets are and then touches around their mucosal, respiratory mucosal areas, this is how they can be infected, and this is how it's transmitted. So in terms of the virus, it has a fragile outer membrane, which is good because it can be killed by simple disinfectants. But there's not much evidence, like in water or in sewage, how long this virus would survive. And on different surfaces, it survives for a different length of time. And studies are continually going, so new information is coming around this. But it can survive from 12 hours to about 6 days. And the survival time in the environment depends on quite a few factors, which include the pH of the environment, the inocular size, or how much concentration of the virus is going out there, the level of dryness of the environment, the temperature, and the exposure to disinfectants, like we said, kills the fragile outer membrane, and the surface type of the environment. Common disinfectants, such as 70% ethanol and bleach, can kill the virus. Okay, this is just a picture to show that on different surfaces, there are different survival times. So once an infected person comes into contact with, once a person comes into contact with an infected person and droplets are emitted, and the virus needs to attach to the cell in a human being in order for it to cause disease. So it attaches to specific proteins, and these proteins are on the surface of the epithelial cells in the upper airways. And so these proteins or these viruses and droplets don't need to be so small as to reach the lower respiratory tract. So if you can see from the picture, in the upper respiratory tract, droplets of about 10 micrometers can get into the respiratory tract, but right at the bottom of the lungs, you need really small droplets that are less than 4 micrometers. However, in the case of COVID, because it attaches in the upper respiratory tract, even the bigger droplets can actually infect people. Okay. So the basic reproductive number, that's the number of people that one infected person can infect. For COVID-19, it's 2.5. That means one person will then go on to infect 2.5 people. And when you compare this to the flu virus, the influenza virus, where we have one person who would usually infect about 1.5 people, and the previous SARS virus, which infected about 3.5 people, but then there's also, it's not as infectious as measles, where one measles case can go up to infect about 15 people. It is generally believed that the people are not as infectious during the incubation period, and people become more infectious when they are symptomatic and when they are coughing and sneezing. So this picture just shows that there is an exposure. When someone is exposed to an infected person, the mean incubation period is about 5.2 days, okay? And can go up the 95th percentile distribution of this. So most people get infected if they are exposed within 12.5 days. So in that period of incubation, they will then become symptomatic. And hence the reason for isolation or self-isolation within 14 days of exposure. With regards to symptoms, of which I'm sure most of you are very aware, the primary symptoms of fever, dry cough, shortness of breath, fatigue is a very common symptom, as well as body aches, but can go on to more severe symptoms like really high fever, even giving you a pneumonia. Okay. So with regards to the case definition, and the case definition then informs who is a person under investigation and who will then require testing. The case definition as described by the NICD on their website is a person who presents with an acute respiratory illness of sudden onset with either one of the following: cough, sore throat, shortness of breath, or fever. Either a measured fever or even a history of fever. And on top of these symptoms, in the 14 days prior to the onset of the symptoms, were in close contact with a confirmed or highly probable case of COVID infection. So they would either have a close contact, or they would have a positive travel history, or they worked in or attended a healthcare facility where COVID-19 patients were being treated. Or in the case of a very severe pneumonia, where other tests have been done and no other etiology has been confirmed. With regards to diagnosis, the diagnosis is by respiratory secretions, nasopharyngeal swabbing, sputum, and a lot more information about this is on the NICD website, and this is the toll-free NICD number with regards to diagnosis, testing, and management of possible COVID-19 infected patients. It's interesting to note that currently, under the case definition, asymptomatic persons are not being tested. And testing is not being done to give people the all clear. Only when symptomatic and indicated, as per the case definition, will people be tested. Okay, so with regards to the outcomes, 80% have a mild, moderate disease. 15% from the data that's now available has shown that they've required hospital admission, of which 5 cases become critically ill and possibly need prolonged ventilation. And the mortality rate is about 1 to 2%. In different settings, it's a little bit different. People who have been identified to be more vulnerable are those with comorbid illnesses, as well as the older age group. The comorbid illnesses can include heart disease, diabetes, chronic respiratory disease, hypertension, and immunosuppression due to cancers and other forms of immunosuppression. And HIV and TB are thought to be comorbid illnesses that could make people vulnerable, but there is not a lot of evidence out there. So once we have noted a person under investigation, they would then be tested, and they would be treated, and they would be isolated. But an important part of the step is contact tracing. So any person who has had close contact with a confirmed case while the confirmed case was ill, or 7 days prior to the onset of illness, is defined as a contact. And the NICD has a list of contacts that need to be filled in for all patients that are positive. And this needs to be submitted to the NICD so that contact tracing and follow-up of these people can be done. So close contact, what is actually meant by close contact? Close contact means face-to-face contact in a close environment that's either colleagues or in a family environment. It can also include healthcare workers or other personnel providing care to this person and who is not wearing the recommended PPE. With regards to traveling patients, close contact would mean people who are within 2 seats within an airplane would be close contact for the infected person. So it's important to do contact tracing because these people need to self-quarantine at home for 14 days, take their temperature daily, as well as look for symptoms. So do symptom monitoring. These people need to remain at home. People need to avoid any unnecessary social contact or travel. And they also must remain reachable because the NICD and the community workers will be contacting them to check up on their symptoms and temperature. Okay. Now, just to revise a few of the terminology. Quarantine is when we separate an asymptomatic person who's exposed from a non-exposed person. Whereas isolation is when we have a sick individual who is infected and sick and contagious, being separated from healthy individuals. Quarantine has been used effectively in limiting and slowing the introduction of a new pathogen into the population. And people can quarantine either in a home setting or in a designated facility. And this oftentimes depends on the level of risk and the intensity of the exposure to that individual. Different levels of quarantine would be employed in different circumstances. So one example is our citizens who came from Wuhan were quarantined out in a designated facility for 14 days. And what has been recommended that is if a healthcare worker who is not wearing appropriate PPE is exposed to a confirmed case, the health worker would be allowed, or who is wearing the appropriate PPE, please note the difference. If a healthcare worker was fully protected and is exposed, they would be allowed to work given the resource limitations, but would self-monitor for 14 days. This changes when a healthcare worker is not wearing the appropriate PPE. Okay. So with regards to treatment, there's no specific treatment, as we know, for COVID-19 infection, but it's mostly supportive therapy and monitoring, as well as monitoring with the person's comorbid conditions, and doing contact tracing as well as isolation. So this presentation is not to cover the full management spectrum of how to treat patients with disease. These are some of the places where you can get information, the WHO website. There's an NICD guidance document. There's also the National Department of Health has given guidelines in terms of management and testing around patients who are infected. Okay. Currently, there are no vaccines, but we have been advised, and hence there is limited availability of vaccines currently, to take the flu vaccine, particularly for our healthcare workers, to prevent not COVID-19 but influenza, so that unnecessary testing for COVID-19 is prevented. Okay. So I'm going to stop there. That is just a brief overview of what is happening at the moment. My colleague, Dr. Mpumi Ndaba, is going to start our talk about what can workplaces do, particularly GP practices and dental practices around protecting themselves as well as their other workers for COVID infection.
Good morning, colleagues. My name is Mpumi Ndaba. I'll be presenting, or I'll be talking to you about potential sources of exposure in the workplace, but also moving on what we could do in our various workplaces. So before I go on with the presentation, I'd like to remind us, I know most of us feel I'm self-employed, I'm in private practice, be it a general practice, a dental practice, or any other private practice as a health worker. Then there are actually two sources of, acquiring infection. It could be from the community, but it can also be from the workplace. But in the end, it affects how we work in the workplace, and we have a duty to ensure that we prevent transmission and protect ourselves. Even before I proceed, I'd like to remind us, because we are health workers, we always come with mentality that our job is to protect and take care of other people. This is one time amongst many other times where we are also expected to take care of ourselves. So for the duration of this presentation, let us remember that we are people in the workplace who need also to be taken care of. And in most instances, we are the ones who are on the driver's seat of prevention and in our workplaces. So from what we know, everyone is at risk of exposure to COVID-19 or to the SARS-CoV-2 virus. But the risk is higher for workers interacting with persons that may be potentially infected. Now that talks to us, the dental practitioners, the general practitioners, any other healthcare workers. And also we know that immunocompromised people, so does it apply to the immunocompromised workers, are also at higher risk of infection. For example, our colleagues or people who work with us who have pre-existing conditions such as asthma, diabetes, heart disease, cancers. We are not sure of the TB, but because remember in South Africa, we have a special case of TB and HIV prevalence, which is higher than what is found in the countries that have actually so far reported the findings. But because of the assumed immunocompromised state during the TB infection and maybe HIV, where you are not well controlled from the ARVs, you are assumed to be also an immunocompromised worker. So we have known from previous information that has been shared that high exposure risk group workers include airline operations workers, be it the cabin crew people, aircraft cleaners, the mechanics, border control, the same. But of note for this presentation is healthcare workers. This includes the EMS workers, this includes the nurses, the doctors, everyone you can think of as a healthcare worker, the pharmacists, but also include the laboratory people, the pathology and funeral services. But going back to the healthcare workers or health workers, we normally only think of the nurses, the doctors. What about other people in our practices who might be receptionists, who might be maybe assistant nurses who help us there? What about people who clean our practices? It might not be an individual practice, but it might be a group of practices together. So we might be having a security guard who's also providing a function there. So as we think of health workers, let us think of all those people, because it's just us, but we're also responsible for those people. But also there are solid waste and waste management workers, carers and teachers, as we know. So if we think of a typical private practice environment, there are some occupational categories that may be exposed in this environment. If you think of our frontline staff, be it we call them receptionists, be it we call them receptionists, or maybe we sort of call them, triage staff, whatever we may call them, but think of the frontline staff. Think of the persons interacting with people through coming to our practice. Think of the cleaners, who cleans the practice. In other instances, you find that our assistants provide all these roles. Who's the security worker? And also, we have a duty to think of the visitors. If I may take you maybe back or maybe provide some exposure, there's legislation, especially in the South African context, which is called the Occupational Health and Safety Legislation, which talks to what should happen in the workplace. This legislation talks to, as an employer, you are responsible for health and safety of persons at work, which is you as a practitioner and any other person who might be at work, of persons in connection with whatever you do, with the operations in your practice or in your workplace. But also we have a duty as employers to protect other people who might be exposed to our operations or people who might come to our practices against the hazards to their health and safety arising from activities from our practices. There is also the Compensation for Occupational Injuries and Diseases Act. This might not apply to self-employed persons, but remember there are people who might be employed within our practices to whom this might apply. So the same occupational health and safety legislation has also regulations. So one of the regulations that is very key at this time is the Hazardous Biological Agents Regulation of this OCCUPATIONAL Act. And this regulation has many sections, it's quite a detailed regulation, but the key areas that this regulation talks to, actually before information and training, it tries to define how these hazards are classified. And it also, defines what's a hazardous biological agent, which I'm not going to go to in detail during this session. But it highlights that as an employer, you have a duty of providing information and training about those hazards. You have a duty, that there are duties of the people who might be exposed to those hazards. A risk assessment has to be conducted. You need to monitor exposure in the workplace. Medical surveillance has to be conducted in line with how the regulations have specified. The records, how those records are to be kept, and then control of exposure to hazardous biological agents. And at the end, it also refers to the PPE and other facilities that could be used as part of controlling or prevention of the hazardous biological agents. So some of the minimum recommendations that we think are relevant for our practices include, we all know, as part of service delivery, we need to conduct risk assessment. Who's in direct contact, who's in contact through their droplets. There has to be some incident management program. It might not be a big program. Remember, it's a practice. There might just be 2 of us working in that program, in that practice, but we need to have a mechanism or program of reporting. If you think you've been exposed, an appropriate follow-up. There has to be a program of continuous improvement. When there's an incident that has happened, we need to look back and say, how can we improve? How can we do better than minimize this exposure? There's also the Occupational and Safety Training Program. It doesn't have to be a big program, but this refers to information sharing sessions or presentations with colleagues in similar environment or in other environment. But also, we know that, especially for us as healthcare practitioners, we need to have, continuous professional development and also take care of the appropriate platforms with colleagues. Remember that we need to minimize meetings, going to meetings, and also consider online and virtual platforms. But also think of the staff within our practices as we go through all these. So as part of mitigating risk in the workplace, we normally separate these into groups. There's primary prevention, which most of us are aware of, and then there's secondary prevention and there's tertiary prevention. During this session, I'm going to try and focus mainly on primary prevention, which refers to minimizing risk of transmission in the workplace. This we do through a hazard identification and risk assessment, and we look at controls. So a hazard in this instance is the virus, and then the risk is the risk of getting COVID disease. And then when we talk about controls, we're looking at those measures that are there in place to try and mitigate the risk of acquiring the disease. So these controls could be engineering, administrative, and PPE. I will do the details later. But at this time, as we mitigate the risk in the workplace, we need to think of business continuity and pandemic preparedness. We know now this is a pandemic. There's no way that we can say we don't know, we are at risk within the country context. So we need to start having some means of being prepared to deal with people who might come to our practices, or even us or our fellow colleagues that we work with, who might have a problem or who might be infected with the virus. And of most important is to educate and train fellow colleagues and communicate this to allay anxiety and to explain what should happen in different instances. In occupational health and safety settings, there's a concept of hazard identification and risk assessment. So hazard identification would be, we know at this time the hazard is the SARS-CoV-2 virus. Risk assessment is when we say, what is the risk? What are the different activities within a workplace that could lend you or could give you the risk of acquiring the disease. So when we do the hazard identification and risk assessment, we look at what Dr. Odette has spoken about, the details about the virus. We look at the details about the virus, the class, the properties of the virus, the droplets being the main mechanism through which this is spread. We look at the host, we've spoken about the risk occupations, we've spoken about other risk factors, people with comorbidities. We look at the environment and controls in the environment. So when we do this risk assessment, we make sure that it is specific to the workplace that we work with. So we're looking at, want to determine what's the risk of exposure to COVID or actually SARS-CoV-2. And we need to communicate to all in the workplace, be it workers and visitors. But also we need to look at other hazards. Are there other biological hazards? Are there other physical hazards? Are there other chemical and economic hazards? And at this stage, we know there's also a big psychosocial hazard in terms of people are exposed to long working hours. There's a sense of panic around, there's an issue of not sure how safe we are. When we do a risk assessment, we need to cover all these aspects. While doing the risk assessment, we cannot just say in this practice, these are the exposure, this is the risk, but we look at each specific person. What are the activities of the dental assistant? What exactly do they do? What does the dental nurse do? What does the dental hygienist do? What does the receptionist and the cleaner do? The dentist, the GP, the physiotherapist, security guard, and any other person who might be within our practice or wherever we work. And customize and look at specific activities that they do and look and go back to the three factors I've mentioned in terms of the host, the virus, and the environment. Are they at risk? So from there, then we can come up with the prevention measures. So some of the prevention measures talk to minimizing the risk of transmission in the workplace. As I've said, that's from the risk assessment, and also business continuity, education, and training. So as we look at all these three main factors, we're trying also to balance. How can we make sure that we ensure maximal minimizing risk of transmission, but also there is some business continuity. So some of the prevention strategies talk to infection prevention and control. We've heard about the hand and respiratory hygiene practices, not only for us as staff who work in the practice. We need to communicate this to people who might be coming to the practice. Please, as you cough, please use your elbow. Please, this is what you do to the hand. But also in terms of the sanitizers and hand washing. The correct donning and doffing and disposal of PPE. This is how we wear and we remove the PPE, but also how do we dispose of PPE? Because remember, we are also responsible to ensure that we protect people who might be within our premises. We need to advise workers on self-assessment, symptom reporting, and sick leave policies. If something has happened, without being punitive, let us know so that we can advise how to assess yourself, should you be in quarantine and so forth. And we also advocate that influenza vaccination should be administered, or people should have access to this to prevent possible co-infection with influenza. And if you may allow me, I need to take a minute to talk about the hierarchy of controls. Controls refers to the measures that are aimed at mitigating the risk from exposure to a hazard. So the broad context, we talk about elimination. Talk about the elimination, where possible, where we can completely eliminate the hazard from the workplace. We talk about substitution, which is not applicable in this instance, but also just for colleagues to remember, we are not eliminating patients, we are eliminating the hazard, which is the virus. The engineering controls, what can we do with regards to engineering controls to ensure that our workplaces, or we eliminate this in our workplaces as ways of minimizing transmission and prevention strategies, and also the administrative control and PPE. So on the next slide, just an orientation, it seems like a busy slide. It's the same hierarchy of controls, but now we've put some context into it. If you look, it's an inverted triangle, the big part at the top, because at the top it's usually the most effective controls, and going down according to the triangle, at the bottom being the least effective. Although I'm not going to talk much about PPE, somebody's going to talk to that. Can I remind practitioners to note that PPE is the least effective of all the other controls that you can implement. And starting with elimination, as I said, we need to eliminate the hazard, which is SARS-CoV-2, which in some instances we might not be able to do that because this is now already in the community and the patients we are treating. And sometimes it's difficult to know if somebody is infected or not, especially if they're asymptomatic. And where possible, we also talk of substituting, but in this instance, we might not be able to substitute like the processes. But then sometimes, we know in this, we talk about that there are other things that we could do to ensure that we do away with some of the processes that are known to be hazardous. And that also talks to isolation and separation, where we segregate the hazards and or from targets and separate, actually, as we're going to talk to in the next slide. Engineering controls refers to those controls that where you need to design or to prevent an unwanted event from occurring. So you design or even mitigate using engineering measures. And then part of the administrative controls, in this instance, are separated into two: is organization, procedure, and procedures. So the organizational controls will include training, competency, and communicating, and also some procedures that we might need to implement. Unfortunately, the administrative controls, the problem with them is that they actually involve, they are relying on the worker or on the person to actually implement them or adhere with them. Whereas some of the other measures, the engineering and the other measures, are actually what the employer can do to actually not really rely on the person to institute them. So the engineering controls, while they also aim at isolating employees from work-related hazard, this is where you reduce the exposure to hazard without relying on the worker behavior, and can be most effective and can be cost-effective solution to implement. So for SARS-CoV-2, some of the hazards or some of the controls that can be used to ensure that we reduce exposure to hazard, especially in our practices, might include installing high-efficiency air filters, increasing ventilation rates in the work environment, think of the isolation rooms, installing physical barriers. You know, some areas we've had, especially in pharmacies, where people have had like a clear sneeze guards, or sometimes some measures to actually separate people or triage people in pharmacies. There's also the negative pressure ventilation in settings where these high-risk procedures are done. For example, airborne infection isolation rooms in healthcare settings, specialized autopsy suites in mortuary settings. So in those areas where we know, it doesn't have to be the whole practice, but based on the risk assessment, where we realize that this is a room where the aerosol generating procedures are done, then this might be the effective control or control to consider. But also another means would be controlled access to high-risk areas, which include, you know, how we're going to talk about designing isolation, and also surface cleaning devices in the form of UVGIs. But in this instance, we've not had any study that has confirmed if these are useful or not. But the use of UVGIs for general infection control measures in the workplace. So some of the administrative controls as part of organization or work organization include having a work plan of action for preparedness. As we said, we need to be prepared now. So there has to be a clear infection prevention and control and standard precautions. There has to be controlled access to practices. Try and avoid overcrowding in high-risk areas as well as laboratories. You know, the waiting areas that are used to at the lab while you're waiting to take whatever specimen or you're coming to collect results, be it, you know, even if it's a private lab. And, you know, think of all the areas where there's potential overcrowding and try and minimize them. And try, where possible, have adequate staff to patient ratio. But at the same time, you look at, do you really need all the people around, or some of the people can be sort of released, or people can actually share some shifts rather than all being around, because they might also increase the number of people in a space at a time. We also need to list all high-risk exposure procedures. For example, this is where we nebulize people, and nebulizing as associated with this is how we're going to do it moving forward. Ensure proper signage and risk communication to staff and visitors. People might be accessing your practice. We also need to review cleaning and disinfecting material and supply procedures. I know that we have been cleaning our practices. They are spot clean, they are super clean. But remember, we've been looking at general infection control. But in this instance, let's review how we do cleaning, how frequent we do that, and whatever we use to ensure that we specifically are covered for COVID-19. But also it's our duty as people who own practices to ensure that we know public health reporting procedures. Which area you might be in, where you might be practicing, you need to know what are the public health reporting lines in your area. But most of all is to create a blame-free working environment. If somebody comes to report to you that they've had this contact or accidental exposure in this manner, maybe I was outside as I was talking to so-and-so, I forgot to do this, the distance was too limited. Let's try and eliminate the blame, but try and look at how can we do it better and use that as a platform for learning. So we know that there's recently been an announcement by the Health Professions Council of South Africa about telemedicine. They actually indicated that all the telemedicine guidelines that have existed, you can change the medicine pass as telehealth. So some of the consultations can be done over the phone, so people don't really need to come in. Although there are some specific requirements there, can you do it with a new patient, or it should also be only a patient that you refer with? To what extent can you do what? And from what I saw on that announcement was that apparently some of the medical aids are ready even to, you can claim for a consultation through this method. But I request that practitioners familiarize themselves with the various medical aids that they use, what is applicable for them. So some of the notices that we can have as part of trying to minimize traffic is, communicating to our patients as well. We care for them even through this time, but everyone should know that maybe we're doing phone contact at this practice, which number should they use at that time? And if also we can communicate that, it's business unusual now. If you need to come to the doctor, maybe you've been advised to the doctor, maybe try and stay in your car or try and call first, but do not come into the practice room while we're not prepared or ready for you. We can rather allocate slots to say you can come at this time and we will be looking at seeing you during this time and that time. So some of the administrative controls as well, as I've spoken about, the telephone screening, telephone consultation, and appropriate and rapid triage, controlled access and ensure proper signage and risk communication to staff and visitors to health facilities. And also look at the cleaning and disinfection procedure, frequency. The important part is the frequency. And if you recall from Odette's presentation, she showed the different surfaces and the duration on which COVID has been shown to last. With proper cleaning and disinfection procedures, that it doesn't mean that it will continue to be there, obviously, but then they do review if you have this metal or this kind of surface, this is how often you need to clean and so forth. And also we need to look into reviewing waste management practices. But what can we do now to prepare our practice? The practice has been in existence, but COVID has come now. We need to be, as we said, display large posters at the entrance, about how we are working, what changes we've implemented. We can use pre-recorded messages, we can send patient SMSs, this is how we've decided to do the change. But some of the minor things in terms of how many people can be accompanying a patient, where it's a child, maybe one person can accompany the child. And actually warn patients that, or our patients that we're not trying to chase them away, we're trying to also protect them and minimize the transmission. And at forefront, we can even start asking some of the screening questions to patients as they arrive at reception. And I've listed the questions there. But what is important is that there has to be a mechanism within a practice. What if somebody says yes to any of this? Where are we going to put them and so forth? One of the other questions that has come up frequently is, what if somebody has come and then you realize they have these questions, or maybe they've said yes to the questions I mentioned before, or they actually might need an isolation room. We need to start preparing in advance for these rooms, and we decide which room is most appropriate for isolation, looking at the other factors I'm going to talk to, in terms of this room should be ideally located away from the waiting area. This room, where possible, it should be away as well from other consultation rooms. This room should not have carpeted floors or soft furnishing. And also, this room should have a dedicated access to its own toilet or bathroom facility. And if not dedicated toilet, maybe there should be another one that is nearer to the isolation room, so that the person in the isolation room does not have to go past the number of rooms to access the toilet facility. But also, when we're isolating now these patients with suspected COVID, you isolate the individual patient. The patient might be accompanied by somebody, so they don't have to go as a group there. It's just the patient who has to be there. Their waste and their belongings. If they have to change, if they have to be in whatever, rather let them go with all of that, so that it's a room and the door is closed, the windows are open. And of importance, our practices might have air conditioners, but we need to switch off any air conditioning in that room, because we're trying to minimize the spread of the virus. The patient should be advised not to touch anything or anyone when walking to the toilet, to wash hands, and also to wash hands thoroughly afterward. We need to reassure the patient and also provide them with updates. Let's say they're waiting in the isolating room. We need to reassure them, we've called this is what's going to happen, and and just ensure that they don't have to be moving around to say, I forgot to pass this message, I want to ask my daughter for this and that. And preferably at this date and time, they should actually be isolated with their cell phone wherever they are, so that they have access to communication, and also the practice could have access maybe to a telephone line. Maybe we should reassure them and so forth. And then we need to avoid now, as the practitioner, avoid entering the isolation room, but explain what should happen to the patient and so forth. And of important, having recognized that now there's going to be an isolation room, there's all of these changes that are happening within the practice, we need to educate and inform employees within the practice. We need to communicate this. How should they handle what? If there's somebody in isolation, the nurse in the practice needs to know how to handle, what are we going to do. But this talks to the procedures I spoke to before, in terms of people need to know this is how we're going to be doing business moving on. And of important, the public hotline number is 0800 029 and 999, should the employee wish to confirm some other information with the NICT. So I'll hand over to my colleague Odette to talk to a specific dental part in dentistry.
Okay. A lot of what was said, there's an overlap, and we spoke a little bit about, the principles of occupational health, where you do the risk assessment, and you look at identifying the hazards, you look at the mitigation and the controls with regards to engineering, administrative, and as a last resort, PPE. Now, in terms of dentistry, we know that one of one of the highest risks. It was even reported on by Time magazine in terms of its production of airborne material during the dental procedures. And this can occur during the tooth preparation with rotary instruments and air ablation, and also during the use of other instruments like air water syringes or ultrasonic scalers, and during air polishing. It was mentioned that ultrasonic scalers and high-speed hand pieces were the most airborne generating instruments that are used. And then oftentimes, even as we sit in the dental chair, we can see that the visible spray is created and splatter. And this often contains large particles of droplets of water, saliva, blood, microorganisms, and any other debris. And this splatter can travel a short distance and settle quickly, but it can land on the floor, on surfaces around the dental chair, but as well as on the dental healthcare personnel and patients. So we know that this is the highest risk of exposure to COVID-19 is aerosolized particles. Okay. So we spoke about that you start with the health risk assessment, and I need to identify all the hazards. And particularly in dentistry, there are numerous hazards, not only COVID, but numerous other infections, including hepatitis B, hepatitis C, HIV. There's a lot of chemical exposures as well, exposures to ionizing radiation, even noise, ergonomic issues with how dentists and their assistants bend over to care for the oral health of the patient. People are also exposed to injuries, latex allergies from the PPE they wear, as well as we previously mentioned the psychological and stress challenges. So because of this high risk of aerosol generating procedures that are used in dentistry, it seems that the global advice has been to postpone elective procedures, surgeries, and non-urgent dental visits, even within South Africa. And it was communicated that practitioners who elect to open during the lockdown period are limited to urgent and emergency visits from patients because of the high level of infection. So why is this that, you know, we're postponing all elective procedures? And it's mostly because it's really difficult to identify the asymptomatic COVID-19 infected patients that are entering our practice. And because of the aerosol generating procedures that are frequently used and the highest risk of exposure to the dental personnel within the dental room. And also because at this time, PPE supplies are also low. So it's interesting to find out what then constitutes a dental emergency, and there are some guidelines. This is but one guideline from the American Dental Association that looks at what are dental emergencies, like uncontrolled bleeding, cellulitis, trauma to the facial bones. It also looks at what is urgent dental care, and it looked at things like severe dental pain, abscesses, trauma. There was a whole list there, and it also defined what non-emergency procedures are. And some of these include extraction of asymptomatic teeth, aesthetic procedures, orthodontic procedures, routine dental cleaning and prevention therapies. So like Mpumi said, you know, we need to put controls in, because even though what's the practice now is to only do emergency treatments for patients based on the assessment by the dental staff around what is urgent and what is an emergency. Some practices can also be put in place to mitigate the risks, even if we are seeing limited patients. One of the practices that can be put in place is to contact patients prior to the dental treatment, to call all patients up, to screen them during this call for symptoms of respiratory illness. And if the person does report, you know, possible symptoms that could necessitate testing and further investigation, to advise them to call the NICD hotline or to attend their medical practitioner first. Like we said, we need to defer any non-urgent procedures, and we can do this, we can assess this over the telephone. Even during emergency situations where staff are coming in to do procedures, limited clinical staff should be present to decrease the number of people that are exposed to a possible hazard of COVID-19. So now just to break it down, so firstly, you know, there are things that can be done proactively to call the patient, but when the patient, once we've assessed for whether or not this is an emergency, within the waiting room, looking at all the controls, the engineering, the administrative controls that can be done. These are just some examples that can be applied to the waiting room. Firstly, like we said, you limit the number of staff on duty. If reception staff is necessary, consider an engineering control where you create a barrier. You have a physical barrier between the patient and the reception staff. Ensure that there's a functional booking system so people don't just walk into the practice, because sometimes they are not aware of this now regulation. Hopefully in a lockdown situation they are. We also need to minimize the time that potentially infected patients would sit in our waiting rooms. We need to, within our waiting rooms, encourage social distancing of 1 to 2 meters if waiting is actually necessary. And some other procedures, if you don't want people to wait in the waiting room, we can communicate that patients wait in their car until they are called by the dental staff. Within the waiting room, we need to limit movements of patients to the toilets, to different places in and out. We also need to limit the number of visitors that accompany the patients, as Mpumi earlier suggested. And we need to prioritize cleaning and disinfection of the rooms and of the waiting room, or where the patient actually sat and what surfaces they frequently touched while in the waiting room. There needs to be instructions, ideally in the form of signages, for patients to know respiratory hygiene protocols, cough etiquette recommendations. So now just going into the actual dental setting where you're sitting in the chair. The kinds of engineering controls we've already spoken about, airborne infection isolation rooms, high efficiency air filters. If these aren't available, because they can be expensive to implement at this time, just looking at one person being in a private room with the door closed, but ventilation, open windows to increase the ventilation rates. As Mpumi spoke about, surface cleaning devices, and also consider the use of rubber dams to prevent aerosol generating particles escaping from a person's mouth. There's just a picture of a rubber dam. We also need to restrict susceptible healthcare personnel from entering the room, and we need to ensure strict infection control procedures, which I know is already in place, but we just need to always re-look at it in the face of COVID-19 with regards to sterilizations, surface disinfection, handlings of sharps, and retraining all our staff on infection prevention measures. We also need to remind our patients about respiratory hygiene, even within the chair, of how they need to cough. We need to, and our patients need to practice good hand hygiene. Whatever personal protective equipment is used needs to be used appropriately, and the correct donning of the mask needs to be done upon entry into the patient room or the patient's space. Ideally, for aerosol generating procedures, the PPE that has been recommended by the WHO is fit tested N95 mask or a high-level respirator, as well as eye protection that could include a shield or goggles, gloves, a gown, and if the gown is not fluid resistant, aprons should be worn. as I said before, correct donning and doffing is really important and needs to be observed so that we don't contaminate ourselves. And like Mpumi suggested earlier, within the treatment room, we need to dispose of any PPE that we are using within the proper way, and thereafter perform hand hygiene. Now, just a short slide because my colleague is going to speak a little bit more about PPE. There's lots of information, around PPE. People feel that there's such a need for PPE, and sometimes even inappropriate people are wearing PPE, or people are wearing PPE inappropriately. So we must remember that PPE is just, as Mpumi showed on this inverted triangle, PPE offers the least protection just because it takes into account workers' behaviours. And the correct way of the PPE use, the appropriate PPE use, the correct donning and doffing procedures, all these kinds of behaviours actually determine how effective the PPE is. And so PPE must always be used within a complete package of other mitigation and control strategies. Those are your admin controls, your engineering controls. Okay. So, and this PPE, which PPE we use for which procedures, is very much dependent on the risk assessment. As Mpumi spoke of earlier, is that we would, in each practice, a risk assessment needs to be done that is worker specific. And based on that risk assessment, it must be then decided which is appropriate PPE to use. Okay? These PPE, disposable gloves, isolation gown, respiratory protection like N95s, eye protection, these have been recommended for aerosol generating procedures. And we mentioned earlier that if it's contaminated, it must be discarded within the appropriate means. But also to remember that sometimes a good way to isolate the droplets at the source would be to use surgical masks for patients with respiratory symptoms. According to the WHO, asymptomatic patients or individuals are not required to use a mask of any type. Okay. So Mpumi spoke about the mitigation of risk in the workplace, particularly COVID-19, and we spoke now to the primary prevention. So preventing in the workplace the actual infection of a healthcare worker and all the controls to look at. But now we're going to go on to speak a little bit more on secondary prevention. And this is to try to identify where there has been an infection, to try to identify the persons that have been infected really early and respond to that appropriately to limit further infection in our workplace. And one of the ways to do this is to do medical surveillance. Okay. So medical surveillance, by its definition, is to ensure early detection, and once it's detected, the facilitation of testing and treatment in an effort to prevent transmission from potentially contagious healthcare worker or health worker to other patients as well as other colleagues. So it's important for staff or hospitals or health facilities or dental practices to maintain a record of all the staff that are providing care to patients who are infected, so that these staff can be monitored for symptoms, and where symptoms occur, they can be rapidly isolated and tested. Now, who has medical surveillance and who needs to be followed up and who needs to be checked for symptoms needs to be determined according to the risk, going back always to our starting point, to the health risk assessment. And in the legislation, it says that the guidance of the OEP. So what types of monitoring can we do for healthcare workers, as well as, either private practitioners, for our staff, in the workplace. We can do self-monitoring, where the worker monitors themselves by taking their fever twice, or taking their temperature rather twice a day, and remaining alert for the respiratory symptoms that people present with if they're infected with COVID-19. There are some tools that can be used. Some of these tools are available on the NICD website that people could make use of. And it's not only important to monitor people, but should symptoms come up, should there be a positive finding in the monitoring, there needs to be a plan that's put in place of whom somebody needs to contact if they're symptomatic and what do they need to do. In the case of active monitoring, often occurs when there's a contact, and as per the NICD guidelines, if a healthcare worker, we spoke about contact tracing prior, if a healthcare worker who is treating an individual who is COVID positive, a list of contacts, they will be included in the list of contacts of the infected patients, and they would be monitored according to our public health system. And other ways we can do monitoring in the workplace can be self-monitoring with delegated supervision of either the occupational health team or somebody that's a medical practitioner that has been placed, delegated with this function. So what happens when an exposed healthcare worker, when we are monitoring them, we're checking for symptoms. If somebody is asymptomatic, they've been exposed to a COVID-19 patient, but they've been checking for symptoms and they're asymptomatic, and the risk is low, like they wore the appropriate PPE when doing aerosol generating procedures and things like that, then they continue with self-monitoring and they continue working. This is a guideline from the CDC. At the bottom, you can see the reference. So please go and have a look at it. In high-risk circumstances, where a health worker is exposed to a COVID-19 patient and they didn't employ there were no controls in place, no PPE in place, no appropriate PPE in place, the risk needs to be determined. In those cases would be high risk. In cases like that, the health worker needs to be quarantined for 14 days and monitored for symptoms, just because their risk is abnormally high. And that's why what we do and how we monitor and how we act actually depends on the level of risk. If it's high risk or low risk, even in the setting of being exposed. However, if the health worker has been exposed to a COVID-19 infected patient and now is symptomatic, there needs to be a reporting line to either their health manager or their facility manager. These health workers who are symptomatic and exposed should be isolated, tested, and sent home, quarantined. So what happens now? Somebody is symptomatic, like the other slide. Somebody is symptomatic, they go home, they're isolated, they're tested, and they're found to be positive for COVID-19. The health worker would be they would be isolated, they need to be treated by their healthcare provider, and where relevant compensation, the compensation legislation would apply, which says that in healthcare workers, where these healthcare workers are employees, they would need to report to the Compensation Commission at the Department of Employment and Labour, as it is likely that they've derived their disease, it's occupationally acquired, they derive their disease out of the workplace. So once a worker has been diagnosed with COVID-19, we still, as a workplace, need to think about when can they come back to work that they are not infective to their patients and they're not infective to colleagues. And there's a reference at the bottom. This is the only reference we have now from the CDC. And its guidance that it gives is there's two strategies that can be employed. You can either have the test-based strategy, where you make a decision on return to work based on negative test results. Or you have the non-test-based strategy, where you make a decision based on a resolution of the symptoms. Okay. So the test-based strategy that has been suggested says that a person can return, or a health worker can return to work on resolution of fever, and this fever must not be produced by using any kind of medicines. There's also not only a reduction in fever, but an improvement in the respiratory symptoms. And when they were tested following this for COVID or for the coronavirus, they were negative on at least 2 consecutive nasopharyngeal swabs collected more than 24 hours apart. On those cases, it's recommended that healthcare worker who has been infected then to thereafter return to work. In the non-test based strategy, it recommends that healthcare workers can return to work where they've had at least 3 days have passed since their recovery in terms of fever and symptoms, or at least 7 days has passed since the first symptom appeared. But it's important that when they go back into the workplace, that some restrictions may be necessary and are also documented in this reference document. The work restriction says that the health worker must wear a mask at all times until symptoms are completely disappeared, or until 14 days after the illness of symptoms, or after the onset of the illness. They shouldn't be around people who are immunocompromised patients for at least 14 days. They need to adhere to strict hand hygiene and respiratory hygiene and cough etiquette, and they need to self-monitor just in case you have recurrence of their symptoms or worsening of their symptoms. So just, I guess we can't say it again, but in summary, we need to, in our workplaces, minimize the risk of transmission. So we need to isolate affected patients, limit contact and movement of these patients. We need to review our health risk assessment within our workplaces again, and we need to look at all the measures with regards to the hierarchy of controls that can be implemented. We need to promote regular and thorough hand washing by employees, by our visitors, by our patients. We need to ensure good infection control and standard precautions are met. Ensure our visitors, anyone in our practice, practices respiratory hygiene and avoids touching their faces, especially while working. And we need to encourage, and like Nkumi said before, we should have a blame-free work environment as we all struggle with this pandemic together, that encourages and even insists on symptomatic persons staying away from the workplace and self-isolating. Okay. So these are some contact details that if there's any inquiries, the red box is for any clinical related inquiries at the NICD. If there are any workplace specific inquiries, info@nihpc.za is a good resource to use. Thank you very much.
Well, thank you very much, Odette. If you just hand that to the next presenter. So that was the combination. Are we on screen? Okay. So that was the combination of our colleagues from the occupational medicine section, Dr. Odette Volning, who was the last speaker, and before her was Dr. Pumindaba, and they were covering a number of key areas, the COVID-19 update section, as well as workplace preparedness, and looking at the different areas, the different categories of staff in both our general practitioner, community-based sort of services, as well as dentistry practices. Our next presenter is going to be on PPE use and respirator fit testing. I welcome Jeanette Mangani, also the head of our occupational hygiene section at the NIOH.
Okay, thank you very much, Ashraf. And I just want to give thanks to my two colleagues who presented a good foundation. I want to mention to our colleagues who joined that the presentation that I'm going to give, it is as a result of many questions which we've been receiving, and to those who have already knowledge about some of the things that I'm going to present, please bear with us. We're trying to answer some of the questions which are frequently being sent to our institution. Okay, so my colleague, this is not a stand-alone presentation, so I'm not going to go through some of the introduction slides which are often presented. We'll go straight to the PPE. So again, with this one, I'm showing you here a hierarchy of control which Umi spoke in detail about it, and she also analyzed each and every element. But what I want to talk about is this one, which is showing in reality that despite that the PPEs are least effective, in this situation, they seem to be the mostly used control measures. So this is commonly used in a TB infection control, but however, I feel it's also more relevant in terms of COVID-19, which is a new hazard. And because it's a new hazard, we find ourselves using a whole lot of PPE while we're implementing other control measures. So I'll give you an example here of an interim guidance, which is showing the rational use of personal protective equipment. Here they are mentioning different occupations and examples of type of PPE which are used. So without indicating which occupation using what, I can tell that there are different kinds of PPE which are used in line with COVID, which include medical masks, gowns, gloves, eye protection, and so forth. So, but I feel the question that some of you may be having this morning is, who should use these PPEs, and what is it that informs the use of the PPE? I know that it has been reiterated between the two of my colleagues who spoke before me, but again, I just want to emphasize that there are key factors which we all need to take into consideration when we want to use PPE. The answer that you will get from us, and even when we come to answering the question, I think that will be the answer that you will hear the most, is that the use of PPE depends on the outcome of the risk assessment. And that should be in line with job activities and the likelihood of exposure to COVID. I know some of you who are not involved in the risk assessment process, you think it's something new, something that hasn't been done before. So those who have been involved in risk assessment process, there's nothing new. What is new here? There's a new hazard, which is COVID-19. So you go back to your current risk assessment or existing risk assessment report, you look at different activities which you have analyzed before and different job activities. Now you have to bring in the issue of a new hazard, which is COVID, and you reassess in a situation where, for example, in a reception area, before people come to see you as doctors, there was no issue of the likelihood of people exposed to a biohazard. In this case, now there is. So in other words, your risk assessment needs to be reviewed to take into consideration the new hazard. So don't panic, don't get worried. It's the same system that you followed before. Now you just have to consider a new hazard in all the activities that you take part of. So the use of PPE should not be used in isolation. So that's why we're showing you the hierarchy of controls. So it is unfortunate that when a new hazard just comes into a space, it finds most of us not ready with other engineering controls because it's the least expected hazard that just show up. So while we fix other control, or while we fix other means like washing our hands, disinfecting surfaces, they used to be, PPE used to be, the PPE should be applied in combination with those other control measures. We know that PPE are less desirable, but in practice, they are used the most. So hence, we are spending more time making sure that whatever we implement, it has to work. We have to get the maximum protection that can be afforded by that kind of PPE that is supplying to people. It is also unfortunate that PPE are unavoidable during emergency situation because, like as I've mentioned, you find that you cannot eliminate, you cannot substitute. While you're working on admin and engineering, it is unfortunate that you have to combine with the use of PPE. You have to select appropriate PPE in relation to the hazards. So in this case, we're talking about coronavirus. So your hazard here, you just need to make sure that whatever PPE, it talks to that in terms of minimizing the risk. And another question that comes often, which has been coming for the past 3 weeks, is the reality is there is shortage. We don't have enough supply for PPE. So we're getting people who have started manufacturing new products, and the question is, are these products good for use? So we don't have the answer for that. But if you want to get assurance, you need to make sure that any PPE that you use and you are making sure that the PPE that has to be supplied to your workforce should meet the design standards or some sort of specifications. Then PPE should also be compatible with other PPEs. Then if you are wearing full PPE in a healthcare setup, it is very important that you don't compromise the effectiveness of one product with the other. So you just make sure that that proper donning sequencing is followed so that all necessary PPE can be used effectively. There's another concept of proper fitting, and it's something else that I've been asked to talk about today. And some of you may be aware of the concept, but those who don't know, this will be an opportunity to be familiarized with the concept. It's the concept of fit testing, especially to those who are expected to use respirators, for example, FFP2 or N95. It's one thing to provide PPE, but if you don't provide information and training, so people who are using it, they are likely to make mistakes. And if they do that, it defeats the whole purpose of obtaining the protection that is desired from the PPE. So it is very important that we train and we inform people how to use PPE effectively. There's also a concept of proper donning and doffing of PPE, including proper sequencing. So that is something that has to be done along with the risk assessment, which also talk about the infection control procedures. So that has to be developed in-house. There are many videos out there, but they talk about different occupations. So for your occupation, you may need three kinds of PPE. Some they need a full gear, but they need to know the proper sequencing of putting on first and the sequencing of doffing, so that you avoid any unnecessary contamination which may result in infections. It's important to know that PPE has their own limitations. So we'll talk about that later on. And if you use PPE, you need to know that proper care, maintenance, and disposal of PPE is very important. So let's address the issue of shortage in terms of supply. We know that, And unfortunately, there is no supplier that I can tell you now that please phone this supplier, they will help you. But what I can mention first is we need to work together to minimize unnecessary use of PPE. I have put in a link there. That is the South African Protective Equipment Marketing Association. These ones, you will find different members of those who are selling or distributing PPEs. I am very much aware that there are new products, so they may not be on that list. So I'm just giving that with caution that I'm not deliberately excluding those who are coming into the market. So you need to be aware of that. So in terms of the new products, unfortunately, if you are planning to call us and check if this product is coming from a supplier which is not listed, can I use it or not? I may not have an answer. But what you need to do is confirm documentation of that product. You look at the performance requirements and see if it's in line with what we need in terms of dealing with COVID. You look at different specifications, perhaps compare with what is already existing, and also look at the standards which has been used to approve that product. Some of the things you can compare product markings, what is it that they're saying about their product. So in terms of the surgical mask and the respirators, we do have SABS standards, which is SANS 1866, part 1 and part 2. Those ones, they can actually help you to look at the characteristics of those products. So you can compare those ones with the new products which are coming. But I'm not saying that they should be exactly the same, but you need to confirm what is it that you're going to get from the product that you're going to be using. Also, I'm advising you to familiarize yourself with South African homologation processes, and that includes specifications which are coming from the national regulator for compulsory specification. And if the product is a respirator or FFP2 to be specific, you need to confirm if it has been approved for your specific requirements. ProTechnique can help you to verify, but they can only verify only the products in terms of respirators which are European approved only. So another strategy for optimizing the supply, we advised on how can we really optimize the supply. We know that under normal circumstances, not the situation that we have now, most of the documentation which come with the product, especially respirators, they're going to mention single use only. It's not realistic at this stage. So we are saying that in your risk assessment, as you propose or you recommend reuse, you need to make sure that you prevent contamination during multiple donning and storage of your PPE. I'm not sure which one you're going to use, but you reuse, but your risk assessment needs to inform that, and it make sure that it gets implemented by everyone who's supposed to do in your own organization. Again, CDC is advising on some of the strategy for optimizing the supply. They're recommending extended use. It can be up to 4 hours or 6 hours. I don't know how practical it is in your own setting. Some, they use those PPE without. Extended use is different from multiple donning. Multiple donning is when you take them off, you put them on, you take them off. There are a lot of breaks in between. But extended use, we're talking about a longer period without removing or putting them on. But we're also sensitized here that we should avoid discomfort, which we want to avoid at this stage. I think the next point here, Odette spoke about it, that surgical masks should be made available for patients with respiratory symptoms. That if you are sick, yes, you can be given a mask, and if you're going to see your healthcare, it's also advisable to prepare your healthcare so that they expect that you are sick when they see you. So in this instance, it means when people call in, you may expect that those who've been educated, they will come to your surgeries or to your practice wearing a surgical mask. So in that instant, if you're going to perform some surgeries or you're going to perform some procedures which are going to be aerosol generating, then you will be expected to wear a respirator. So that is another condition. There are also information out there which I'm not yet too much knowledgeable about that, but we know that there are different methods that are being trialed in terms of disinfection or decontamination of N95 respirators using different methods, UVGI, sodium peroxide, microwave, and so forth. So those ones, I am not in a position to advise which one is better or which one we can use, but I believe that as much as the situation is evolving, new knowledge is coming, and we will be able to really be confident to advise specifically. So now I need to move to respirators and masks specifically before I introduce the second concept, which I was asked to talk about it. I know there is a difference, there's also a confusion about what is a mask and a respirator. So I want to clarify, because when you do your risk assessment, you need to be specific. A mask is a surgical mask, and a respirator is FFP2 and N95 in this case. So I know we use these two terms interchangeably, but it may cause a lot of confusion in terms of allocating resources for provision of PPE. So you need to be very much clued up or knowledgeable about what is it that you're recommending in your report. So a surgical mask, it works one way. So in other words, you are protected from the person who's coming to you wearing a surgical mask. So a respirator, it works both ways. So in other words, as a doctor here, you will be protected from me, and at the same time, I'll be protected from you. So we need to know the difference so that we advise accordingly. So in terms of the respirator, to work effectively, it may be late now or it may be a good time to start. In order to make sure that it works effectively, there must be a respiratory protection program, which include policies, like in your case, there must be a support from management. If you're running your own practice, you are self-employed, there must be, like, you understand the principle and the rationale for using the respirators. You need to have selected based on some of the reasons that are in some of the elements. You must be able to be to have done medical evaluation, which I know that most people haven't done that. In other words, we're saying that there are people who cannot wear a respirator, or they struggle to wear a respirator, especially those who are asthmatic, or maybe those who face challenges in terms of the breathing. So they may struggle, and you have to think along those lines when you talk about extended use. And lastly, if you, as a doctor, you are expected to perform some procedures which will need a respirator, that's when you need to do respirator fit testing. That's why women Odette kept emphasizing that a respirator should be the fit tested one. You should have been fit tested. Then again, I just want to clarify three concepts which are confusing. Every day when you wear a respirator, you fix it, you put it on, you must do a seal check. That is not a fit testing. Filtration efficiency test, the fact that we're talking about N95, it means it filters at least 95% of the particles. So that is filtration efficiency that we're talking about. The fact that FFP2 and N95 are equivalent is because FFP2 filters at least 94% of the particles. So the other one's 94, the other one is 95. So there's no respirator that it filters 100%. So that we need to know, so that when we don't do fit testing, we are sort of again allowing another limitation which will defeat the full protection. So the full protection is also limited to those filtration efficiency level. So when you do fit test, you want to make sure that the respirator that you're going to use, it fits you as an individual. So if you are in a group like doctors in one health sector, you have to all go through this process, because you cannot use one size that that someone got a fit on it and then you apply to everyone. And by doing fit testing, you want to make sure that you are confident that every time when you wear that respirator, you are protected. You maybe at all, you may not using respirators at all, but now with the new hazards, you may need to consider to do that, especially if you're going to perform procedures which are going to put at a risk of exposure. So there are two methods that you can do fit testing, qualitative and quantitative, but I just want to mention something which is relevant to the situation at hand, that CDC is currently recommending qualitative fit testing because it minimizes the distraction of N95 respirators which are used. It can be FFP2 in this case. So in other words, when you fit test 100 people using the other method, which is quantitative, because we probe a hole, you are likely to discard 100, as opposed to using qualitative where you can still use the respirator that you used for testing. So these are some of the factors that will affect fit. So just to remind colleagues, is only those who are required to use N95 or FFP2. This is very important for you. So if you have facial hair or beard, then that respirator won't fit you. Then if you put it incorrectly, it's not going to fit you. If you use the incorrect size or shape in line with your facial features, it's also not going to fit you. Then it has to be put on correctly. Remember, some of the procedures you are required to wear safety goggles. Then if you don't put it the right way, you are likely to compromise how the respirator fits on your seat around your face. Then again, the issue of multiple donning and doffing, people forget the technique that they have to do seal check every now and then when they put it on and off again. So I would like to end up by talking about some of the limitations with regard to PPE in general. So the hazards still exist. So we haven't taken away the hazard. So that's why, where possible, we really need to think of other engineering controls. Then we use PPE as a supplement. But often case, PPE are used first and the others as a supplement, which it shouldn't be like that. You are again working, the effectiveness of PPE is dependent on users' behavior. Then if the person that is using the PPE is not cooperating, is not following good protocols, then you are likely to have false protection in your organization. Then we also need to be aware that there is no one equipment which protects against every source of infection. That's why in this case of corona, if you are likely to touch surfaces, that's why the gloves are there, that's why the safety glasses are there, the respirators or the gown for some of the processes. So if you do engineering, you happen to eliminate the hazard before it comes to different areas where you need to protect yourself from getting contaminated, which could result in infection. So if you're not using it properly, it's gonna defeat the whole purpose. Then the use of PPE sometimes may restrict movements. You can affect your vision, communication, and comfort. So we need to know that as much as we feel it's easier to implement, if we can do engineering, we can eliminate some of these things which we are working on an individual than the hazard itself. It should be properly maintained. Like I've mentioned that now the ideas of decontamination or disinfection of PPE, if it's not done properly, then it may introduce another hazard which we don't want. So we must be careful what is it that we're introducing in terms of applying some other means of maintaining of PPE. It requires regular training. So with time, or even now, because people are working under pressure and so forth, we need to sensitize ourselves that as much as I'm rushing to do this procedure, I need to focus, I need to understand that if I'm relying on PPE, let me make sure that I put them and I use them effectively so that I can be protected. So in other ways, improper use of PPE will create false protection. So it means that exposure will still exist even if you are wearing the correct type for the hazard. So these are some of the sources of information that you can really refer if you want to know more about PPE. And I just wanna mention again that if you need more information, those are our details. And thank you very much for listening.
Thank you very much. And that was the head of our occupational hygiene section here at the NIOH, Jeanette Mangani. Our next presentation is going to be by Anika Matuka. She will be dealing with the cleaning procedures for surfaces, floors, and equipment, for example, including the stethoscope and dental instruments. And as I'm welcoming Anika, please, I would like to remind you, for those who have not yet added your details in the chat box at the bottom, please type your title, name, surname. Your city would be useful for us to know, since we've reached the maximum of 500 people logging on to this Zoom session, as well as your email address, and if you want to, your cell phone number for future bulk SMS notification. Anika, thank you.
Thank you, Ashwa. Today I'm going to present to you cleaning and disinfection procedures, which forms a critical part of infection prevention and control. For two reasons: because we need to keep our environment free from contamination with microorganisms, and secondly is to protect the workers or employees in their work environment. So firstly, we need to differentiate between the two terminologies, cleaning and disinfection. So cleaning is defined as removing foreign material or even impurities from surfaces, and that may be use of detergent or enzymatic cleaners and water. But it does not necessarily kill germs, it just removes those impurities or the dirt or dust from the surfaces, and it lowers the risk of spreading of infection. Whereas disinfection, it does not clean the dirty surface. It may disinfect, but you may still have residuals of dirt on the surfaces. It uses chemicals to kill the microorganisms on the surfaces, and it kills germs. That's the step after cleaning. It's followed by disinfection, and it can further lower the risk of spreading the infection in the workplace. So the use of correct disinfectants is critical in this instance in order to prevent and reduce the spread of disease, COVID-19 in this case. Disinfectants may not work on all surfaces, as you get different surfaces. You get porous surfaces, you get semi-porous, as well as non-porous. So usually your disinfectants will likely work best on your non-porous surfaces, as they cannot absorb the chemical or the solution. But there are different types of disinfection procedures as well, depending on what you're using. So you know better what you're using in your workplaces or in your surgeries, so and the type of material that you're using. So choosing a proper disinfectant is important, because you also don't want to damage what you're using in your settings. So you can either steam sterilize using autoclaves for the semi-porous or for other instruments, or you can use chemical vapor. In some settings they use chemical vapor, such as your formaldehyde or your hydrogen peroxide, etc. Or dry heat can be used for those items that are heat stable. So some disinfectants can be very toxic. So as previous speakers have mentioned, risk assessment is important in that case. So when you're going to conduct your risk assessment, while we are concerned about the contamination, we want to keep our environment microbial free, we should also think of our employees, because we need to protect them from exposure to these harmful chemicals. So when putting mitigation strategies, when you're going to decide on what disinfectants to use or which ones are relevant for the coronavirus, for now. So you need to also know that the workers need to be provided with the correct PPE for using those chemicals. And they need to be trained also on the hazards, the risks that they are exposed to, as well as what control measures you have in place for them, for their protection. And it's critical, I think, at this stage to also put together a standard operating procedures for your decontamination or disinfection processes, so that employees will find it easy for reference to look at, because you don't want also the workers to interchangeably use the wrong chemicals for certain procedures. They need to know which specific chemicals to use for which activity. Some disinfectants can also be expensive, so it's important to consider your budget as well while you're putting control measures into place. If you're working for a bigger facility like your public facility, then you need to work in consultation with your procurement department or your financial department. But if you are an independent practitioner, then it's something to think of when budgeting and putting control measures into place. So the World Health Organization and the Center for Disease Control and Prevention recommend that appropriate disinfectant with proven activity against envelope viruses, in this instance it's your coronavirus, must be used to minimize the risk of transmission to COVID-19. So examples of the active ingredients that should be in the disinfectants that are chosen are the following: your hypochlorite solutions, or bleach, or jig, as it's commonly known, and then your alcohol. It must at least be 60% alcohol, but preferably 70%. Then you get your hydrogen peroxide, your phenols, as well as your quaternary ammonium compounds. So that list is the active ingredients that should appear on the ingredients that's showing on the container or the label of the disinfectant that you use, that can be effective against the coronavirus. So the disinfectants, they can either come concentrated, whereby you need to dilute them, or they can come ready to use as diluted. Then you'll find out, if you check at the labels, some of them, they come as individual active ingredient on the disinfectant, or some it will be a combination in order to boost or to supplement the microbial activity, antimicrobial activity of the agent. So it's important to follow the manufacturer instruction or the product label, as different suppliers will have different composition or ingredients on their chemicals, and you cannot use the other method for the other reagents. So as much as you're going to put together an SOP, which is your standard operating procedure, you must always make sure that you revise it as you change your brands or as you change your disinfectants. So for surfaces, you get them in the form of liquids, or you get them as powder, which need to be diluted in water or some other solution. Then you get your surface wipes, which has been discouraged in some instances by certain researchers, because firstly, they dry out quicker, and also they affect the contact time when you have to disinfect your surfaces. So frequently touched surfaces must be disinfected regularly, especially those spaces that are shared by several individuals. I've listed examples there, like your equipment that are shared, the doorknobs as you're getting in and out of rooms or surgeries, your desk where you do your consultations, and chair sites for dentistry, as well as the computers as they are closer to the workstation, as well as X-ray equipment and tapes that are used during the procedures. So for the individual or for the employee, hand sanitations or hand washing is important. So that comes in the form of antimicrobial soaps. For coronavirus, although it has been recommended that you can use any soap to wash, antimicrobial soaps are usually recommended for those organisms that are resistant or have shown resistance. But so far, coronavirus hasn't been proven to be resistant. Then you get your hand gels as well as your wipes also for the hand hygiene. So hands must be cleaned at the door and at regular intervals. So regular intervals is a broader term, but as a worker or employee, you know what activity you do. So basically, you must actually wash your hands in between any task that involves possible or potential contamination or contact with your hands, or if you're doing a clean procedure, because you also don't want to infect your patients with contaminated hands or transfer contamination to your patients. So gels must also be allowed to dry when using them, and there is no rinsing required when you're using gels. And most importantly, a proper hand wash technique must be followed as recommended by WHO. So if you can go onto the NIOH, there are many resources that are showing the proper hand wash techniques. They are available for your access or for your review. Even on the WHO website, you will still get. So dirty surfaces must be cleaned with detergent or soap and water as mentioned before the disinfection procedure takes place. And use of protective barriers for chair, switches or light handles in the case of your dental surgeries that can be used, especially for surfaces which are difficult to disinfect. Rather use something to cover that you know you will just remove and you can dispose of. And then disposable gloves must be worn when cleaning and disinfecting surfaces and must be disposed after each cleaning. So proper disposal procedures must be followed. I'm sure my co-worker who's coming after me is going to cover waste management. She will cover that in her presentation. So, and then if reusable gloves are used, for instance, for your cleaners who usually use these domestic gloves, they should be dedicated to each area and must not be used in different areas, as that can transfer contamination from one area to another. And if they are used, the reusable gloves, they must also be disinfected after using by immersing them in a beaker with the solution, with the relevant disinfectant diluted in water. And the gloves must be dried properly after disinfection, or alternatively, there must be spare gloves for the cleaner or for the user to use while waiting for the other gloves to dry. The employee should supply adequate cleaning materials for healthy hygiene practices so that your environment can be cleaned at the time that's needed, and also to protect everyone that is working within the space or the area. And then the supplies must also be accessible, especially in patient care areas and change rooms. You don't want to be storing disinfectant far from where you're working, because there you are increasing the risk of transmission or the risk of contamination, as you need to go out the door to another room, touch the cupboard door to open to take the disinfectant. Already you have contaminated your doorknob, you've already contaminated your cupboard handle. So rather have them near where you're working to avoid cross-contamination. So it's important to know the factors that are affecting the efficacy of different disinfectants. Effectiveness of various disinfectants depend on several factors which should be noted when you're applying disinfectants. So the concentration used is important. As mentioned, you may get a concentrated disinfectant which you need to dilute. So manufacturer's instruction or the label must be followed. The user must know how much of the disinfectant I need to dilute in how much of water. That's critical for the antimicrobial activity of that solution. If you're going to dilute it wrongly, it's not going to serve the purpose which is supposed to serve. So the ready-to-use one, you will see sometimes they come showing the percentage effectiveness of the disinfectants. Some will say 95%, some will say 99%. So you already know then what concentration you're dealing with. So increased concentration will increase the efficacy of the disinfectant, and then it provides you with shorter time period of contact of the disinfectant with the surface. So depending on the activity that you're doing, how much time you have in going to the next step as you're going through your steps during your processes, you will choose the disinfectant with shorter time when you're doing activities that needs your quicker response or faster response, because you don't want any delays of 20 minutes contact time or 10 minutes contact time, for example. So while purchasing your disinfectant, also make sure you check your contact time, which I've also covered on the slide there, which is the time that it takes for a disinfectant to remain on the surface. So, or sometimes they refer to it as the air exposure time. So that determines how long you can use or you can disinfect your surface before you proceed with your activity. So the ingredient is also important. As mentioned, your active ingredient that has been recommended by WHO. So those 5 ingredients mentioned on the initial slide should be looked at. Your storage condition is also important, as your temperature can affect the antimicrobial activity of your disinfectant. pH as well has been shown to improve microbial activity for certain disinfectants, such as the ones that will contain your ammonium, your quaternary ammonium compound, whereas it may decrease that of others, the activity of others, such as your hypochlorides and your phenols. So it's important to also take into consideration pH as a factor that can affect efficacy of your disinfectant. The volume that's been used is important. So here you follow the manufacturer instruction that should show on your container, especially for hand sanitizers. You will be told to either have a press, one press will give, for example, a volume that's equivalent to 2 ml and so on, depending on the manufacturer also. So you need to follow manufacturer's instruction. The location of microorganisms. Some items can be designed in such a way that microorganisms can hide between the grooves or between the joints. So in this case, you'll either need to take the entire item, immerse it in your solution with disinfectant, or you may need to dismantle your equipment if possible. Then put the pieces in there, following the manufacturer instruction of how you should be disinfecting them. So I won't be specific on how you should do it, because different manufacturers will give you different instructions. So it's important to follow manufacturer's instruction. So inorganic or organic matter can also interfere with antimicrobial activity. That's why this step of cleaning first is important before you disinfect. Because if you don't clean, these impurities may act as a barrier and cover your microorganisms, and your disinfectant may not reach or come into contact with the target organisms to clean, in this instance, to be your virus, the coronavirus. So compliance of the disinfectant is also critical. You will see some reagents will show you which standards they followed for the manufacturing or which accreditation body they used to accredit their products. So we've all seen everywhere now, especially with shortage of this hand sanitizers and so on, your disinfectants, there's been a whole lot of manufacturers. So when purchasing, pay attention to your reputable manufacturers. You don't want to buy a product that you don't know. I've seen already some few has been placed on shelves. They didn't even have a label, but they say when you ask, they tell you, okay, it's 70% ethanol. But how sure is the buyer? How would they know if that is the real product or the right concentration of that particular disinfectant? So that's something also to pay attention to. So I've mentioned safety already, as these chemicals can be toxic. So it must be important that the user or an employee must make sure there's access to the material data safety sheets for reference for the employee to refer to. This MSDSs will tell you firstly what the chemical contains or the composition of the chemical. It will tell you the hazards associated with the chemicals. It will tell you the risks associated with that, and it will tell the user how to protect themselves from using this chemical. And even the environment, what type of environment or your environmental conditions to use this chemical or disinfectant. So also when using disinfectant, especially in enclosed space or enclosed rooms, it's important to ensure adequate ventilation in those rooms, as there can be residual vapors or residual fumes which the worker may be inhaling or be exposed to. So this air circulation can be in the form of your natural ventilation by opening up windows, supplementing it with fans if there are fans available to help with air mixing, or if there is mechanical ventilation, that's still sufficient. And most importantly, also users must be trained on how to use PPE and must be provided with the PPE and must be trained on the overall hazards associated with using this disinfectants. So this is just an example extracted from the list of the Environmental Protection Agency of the registered disinfectants that they are on their list. I'm just showing similar examples of the quaternary ammonium compound, which I mentioned earlier on as an active ingredient. This requires contact time of 10 minutes as compared to your hydrogen peroxide or peroxyacetic acid, which is also commonly used in dental surgeries, which requires 1 minute exposure. As mentioned, you will determine based on your risk assessment and your procedures which one would use in your facility and include it in your standard operating procedure of your decontamination processes. So this is just an example of a disinfectant that's been used. I just wanted to highlight a few things that this item comes as undiluted, so you need to dilute it before use. And then they've indicated here on directions for use that approximately 3 ml is equivalent to 1 pump. So that's the volume required to use for your hand wash. And then the contact time, there is a shorter contact time, which is 1 minute contact time. However, this container didn't show the expiry date, which is a concern also, because you need to know how long you can keep this chemical, as the chemical stability depends also on the shelf life of the chemical. So you may keep it for long, not knowing the expiry date. Meanwhile, it's inactive, it's not doing the job anymore, and then you'll be at risk of exposure to microbial contamination. And then the other thing, they do say that alcohol here, they have ethanol, they have isopropanol. Remember I mentioned that you can either get them alone as the one ingredient or combined. In this case, you can see there's a combination of 2 alcohol, but in this case, they're not showing the percentage. But this label must be used in conjunction together with the MSDS, because it may be that it's not showing on the container, but the details may probably be in the MSDS. So we use the two, the document together with the label concurrently. So this is just an example of an MSDS, which will show you what is the recommended use for that disinfectant or the product. This is an hand sanitizer. Then they will tell you the chemical nature. That's your active ingredient with, that's the main ingredient, which is your 70% alcohol. But you'll see here ingredient listing. So it's been combined with other things as well, your triethanol, amine, and so on. And then it will tell you it's a flammable liquid, which category, and also the health effects associated with the use of this disinfectant. These are just recommended sites for additional information. WHO and CDC. CDC has got that the disinfection for healthcare in that, and they also have a guideline which shows you, guideline for disinfection, which shows you or tells you which chemicals are available to use as disinfectants and their antimicrobial activity and for which agents they can be used, like various microorganisms. And then you get your EPA, you get that full list of the registered disinfectant on that website with all the list that's showing all active ingredients for different products. Then there's other links that's useful, where you can get useful information with regards to decontamination or disinfection procedures. Thank you.
Thank you. That was my colleague Onika Mangani from the Immunology and Microbiology section. Thank you for that contribution with regard to PP. Did I just say that? I did. Wrong name. Correction. That was Onika Matuka, doing cleaning procedures for services, floors, equipment. Thank you very much, Monica, for that contribution. My mistake. Okay. We intended to share with you today a donning and doffing video, particularly within the context of COVID-19. And we're in the process of redoing that particular video to ensure that we're completely up to date. But we will let you know through the contact details we've provided for us when we are going to upload that either onto our website or onto the YouTube channel. We'll certainly keep you informed about that. And for those who have not yet provided your contact details, please provide that for us in the chat box. Somebody did mention somewhere in the chat box, why are you sharing your contact details with everybody? You can in fact select when you're in the chat box only to share your information that you might regard as private with the panelists, and then that would get to Glenn, I think, in particular. Thank you very much. So our next presenter is going to look at healthcare waste management considerations, and that's my colleague, Michelle Hawley. Welcome.
Thank you so much, and good afternoon to colleagues. I know I have a thick voice, I hope I'm audible. As it has been mentioned, my name is Michelle Hawley. I'm the Manager of Waste Assurance in the National Health Laboratory Service. So I'll be talking to you this afternoon mainly about waste management, but we added about 2 slides just to re-emphasize what Onika has said earlier on about cleaning practices. So I'm not going to dwell on the cleaning practices on these first 2 slides. I'll just take you straight through to our slide, because basically these slides are repeating what Onika said earlier on, so I don't think there's a need for me to really say much on that. The same applies with this slide, so I'll just go directly to our waste management. We all know that in our healthcare establishment, we generate waste. And this waste is basically divided into general waste and hazardous waste. By general waste, we mean your packaging material, your office paper, your flowers, cold drink cans, and your food waste, and so on. And by general waste, we mean your sharps waste, your infectious waste, anatomical waste, chemical waste, pharmaceutical waste, and other waste, hazardous waste streams. And for us to manage this waste in a safe and legal manner, there are a few things that we need to do. Firstly, we need to ensure that staff members or those who are handling waste within our facilities are provided with appropriate PPE. And this PPE, or what you provide in terms of PPE, will be informed by your risk assessments in your facilities. And to ensure that we manage our waste legally, there are a few steps that we need to follow. Firstly, we need to identify and classify our waste. By this, we mean that we need to identify, is our waste general waste or is our waste hazardous waste? And once you have determined whether your waste is general or hazardous, then you will know how to manage this waste. Firstly, we have, in terms of general, or I'll end with general waste, with hazardous waste or healthcare risk waste in particular, we have specific containers that we are required by law to use. We have our red containers, and this other red container with infectious waste box. These two containers, basically, we use them for anatomical waste and we also use them for infectious waste. Then we have our yellow sharps containers. This we use for our sharps. And we have our green containers for our pharmaceutical and chemical waste. And lastly, we have our black or transparent or beige containers that we use for our general waste. So you use these containers to place your waste, and in terms of COVID-19, we understand that we don't have to use anything different from what we're using daily in our facilities. The third step is to ensure that you close and seal your containers properly. Firstly, you close and seal the plastic liners that are mainly used in the infectious waste boxes and the anatomical waste buckets. You seal that liner with a cable tie, or if you don't have a cable tie, you can even use your biohazard tape. And then once you are done closing that first or the primary container, which is the plastic liner, you then use or you close your secondary container. This will either be your bucket or your infectious waste box. And then you seal it properly and preferably with the biohazard tape to ensure that there isn't any, or to limit any spillages that may occur. Then the fourth step is to label our waste containers. In terms of the guidelines that we're using in South Africa and the relevant pieces of legislation that we use, we are required to label these waste containers. We don't just give it over to the service provider without labeling it. So on your label or on the container, you need to firstly write the date that you started using that container. If, let's say, you started using your container today, which is the 31st of March 2020, you will write 31st March 2020. And then after your container is sealed, you then write the date the container was sealed. If it's going to be maybe on the 1st of April, you write the 1st of April. Why do we need to write these dates on our containers? Is so that we can tell the duration that that container was used for. Because by law, we need to make sure that the waste that we generate is treated within, in terms of the SANS 10248, we are given a period of about 90 days from the point of generation up until that waste is treated. So hence we need to know, or the authorities will also want to know, when did you start using that container? And that also helps you as well in your facility to know for how long has that container been there, and also to limit any potential contaminations and so on. So it helps a lot in the facilities. And still on that container, after you've sealed it, you need to write down the name of the facility. And where possible or where required by law, this in our case, it would be in the Western Cape and in Gauteng, that you also need to have your waste information number that is provided by the departments that are responsible for environmental affairs in these two provinces. We are required as generators to put down our waste information number where it is applicable. The name of our facilities and the date that waste was generated. And if you have different departments within your facility, you also need to indicate where that waste is coming from within your facility, so that you are able to track. Should there be any query, you should be able to track where that waste was coming from. The fifth step, this step says to us that we need to store our waste. Those filled containers, filled and sealed containers, need to be temporarily stored in designated areas before they are removed by a waste management contract. That we are aware that we have facilities where it's just a one room, but you need to dedicate an area within that one room where you are, with that area that is dedicated for temporary storage of waste before this waste is removed by the contract. And in addition, you need to make sure that you separate the waste, the COVID-19 waste. I'll talk more about it later, but the COVID-19 waste needs to be separated from our ordinary biohazard waste, so that the contractors can remove it in time and as quick as possible, and then it's treated as soon as possible. The sixth step says to us we need to keep records of all the waste that's been removed by our waste management contractors, and specifically our healthcare risk waste. Service providers or our contractors need to generate what is called a waste manifest before this waste is removed from the facility. The information that is going to be on your manifest, it's that, the same as that information that we ask that you put on the label. You need to indicate the name of the facility, you need to indicate your waste information number if required, you need to, that document needs to indicate the types of waste that are being removed. It also needs to indicate the quantities of waste that are being removed. It needs to have the details of the service provider and the details of the facilities. And then lastly, you need to keep records of, this is in step 7, you need to keep records of proof of waste destruction. So after your waste has been removed, disposed or treated, the service provider needs to come back with what is called a proof of destruction, then so that there's proof that the waste that you have issued to them or handed over to them for treatment or for disposal, it has truly been destructed and or disposed accordingly. So the documents will indicate all that. And lastly, in addition to the guidelines and the standards and the pieces of legislation that we use on a daily basis, the Department of Health and the Department of Environment, Forestry and Fisheries have come up with guidelines and or directives that we need to follow as generators of waste, and that the treatment facilities also need to follow. But then as generators of waste, this is what we are required to do in addition. We are required to clearly write on the waste containers COVID-19. This is specifically for waste that is suspected to have either been contaminated with the coronavirus, or maybe you have come in contact with the waste that was generated from a patient that is suspected or confirmed to have coronavirus. So you need to put this, write this on your container, and as I have mentioned, the reason mainly is to ensure that that waste is given priority by the treatment facilities. Secondly, we are required to wipe down the silk container with a 0.5% hypochlorite solution. So before you remove the waste container from your facilities for temporary storage, or before the waste is removed by the waste management contractor, it needs to be wiped down. Thirdly, you need to make sure that your contractor is aware that you are generating this waste from your facility, so they can make the necessary arrangements to come out and collect that waste and prioritize your waste. And lastly, your waste management contractor should collect and treat your waste as soon as possible. And with that, thank you for listening.
Thank you very much. And that was from our SHE department at the National Institute for Occupational Health, my colleague, Marcella Khole. Now I'm going to ask everybody in a moment to come forward, but for now I'm going to ask Glenn just to share the slide. So you probably know many of the items on that list there, sources of information, and from the NIOH down to the websites of the NICD, our sister institute dealing with communicable diseases, the NHLS, our mother body, the Department of Health, Department of Labor, the World Health Organization, the Center for Disease Prevention and Control in the US, the International Labor Organization, and then the key hotlines, which I'm sure you all have stuck up in your surgeries and dental rooms for your patients and visitors to see. And that's from the NIH one, very critical. The first one for you is the occupational health practitioners, and that's for people who are specialized, and then the healthcare workers. So if there's colleagues of yours that are specialized in occupational health, please refer them to that hotline. And then the general public for the healthcare workers, or health workers broadly, that would be applicable for you as well. And then you're familiar with the WhatsApp line that's been set up by the National Department of Health. For COVID queries, please, there again is our email address. Anything that you haven't not typed questions or other requests, many of you requested the presentations and you've asked for other information, that email address at the bottom, info@nioh.ac.za, that's critical for you to have. Now, I've just asked Glenn to briefly just flip up the NIOH website, and this is the website. I'm not sure if you can click on that one. Is that a link, Glenn? Glenn will just quickly go to his browser to set up the NIOH website. So I quickly want you to just scroll down, www.nih.ac.za, and we have the front page dedicated to COVID-19 specific resources. And those resources include, I'll quickly bring up my one. Those resources include the following. Right at the top, you have the COVID-19 resources, NIOH resources, and NIOH COVID-19 occupational and safety resources. My colleague just is bringing the chairs 1 meter apart, as you would expect it to be, to the front so we can have our panel discussion. And then there's the COVID-19 fact sheets as well, you'll find on our website. I'm not sure if that's on our screen now, Glenn. No, okay. And then there's the frequently asked questions that follows just below those three pictures for resources. And then at the bottom we have COVID-19 training videos as well as the training schedule. Yours will also be in the updated schedule. We don't have that there. I'm now asking my colleagues to join us. And I'm just going to make sure that Glenn's got us all on the screen. Are we more than the 4 that we normally are? Oh, we are. Well, look, let's make some more space. Okay. So maybe people come. I'm going to zoom this out. Okay, that's the best thing to do. Then. To just create some more screen space. No, I can't. Okay, well, then we're going to do it manually. We are going to do that. And do we get more people in when we do that? Yes, this is Anika. We need to get you. So I'm going to ask if this table could just slightly be moved. Sorry, Simpiwe. My apologies, a bit of technical shifting. Is everybody there? Anika slow. Is Anika in? No. Okay. All right. I'm going to move slightly forward so you can at least just see or hear me. So from your far left is Anika Matuka, and next to her is Jeanette Mangani, and then Michelle Khole, then Dr. Odette Volming. But that right next to me, none but not least Dr. Kumida. Occupational medicine, she, the section dealing with our occupational hygiene as well as immunology and microbiology. A good collection of my colleagues. I think it's the biggest collection I have for the biggest audience. Okay, so now I'm going to ask some people just to help us with those, the Word document on the screens if you read. We won't be able to add any more questions. If you just scroll right to the top, and then we'll start with the questions from the top. Now, some of your questions might be repeated, so we'll cover those without repeating questions. So I think around 10 past 10, Debbie Lombard added a question asking, what is expected of our dental assistants? Are they expected to help with emergencies? Now, I'm not sure who do I direct that question to?
As long as they register with the Health Profession Council.
Okay, so that comment is from Tamisha. You want to add something to that?
No, I think that you know, even with that, they would be a very high risk worker, given the aerosol. They're in such close contact with aerosol generating procedures that a risk assessment needs to be done for them, and all the measures, the mitigation measures, needs to be almost similar to the dentist who's performing the procedure.
Thank you, Tamisha. Thank you, Odette. The next question I think we are not able to answer on what grounds I think time with the lockdown. Unfortunately, the occupational health and other public health professionals are being consulted in those processes, but that's an issue they can at a different level at a different place. The next question is not risky, too fast. There's a question below that one. It's the same one. Okay, so, okay, next one. Thanks, Julie. Kindly confirm if it's spread through contact, air droplet, or airborne or not. Because there was some speculation, you know, that COVID-19 was not airborne. And I think the World Health Organization has answered that.
So currently it's been reported as droplet transmission. But there have been researchers that have been investigating the possible airborne transmission, and there's a few publications that's out on that, but we will wait for the World Health Organization to approve and say, like, put a stamp to say it's there. So there isn't basically enough evidence to show airborne transmission.
So for our GP and dentist audience in a particular practice, I think our presenters have covered that question adequately in indicating which are the procedures that you're involved in that might aerosolize the COVID-19 or the coronavirus itself. Okay, so the next question is, do cleaners have to have the full PPE, or should this not be the case if departments of simply treating confirmed COVID-19 cases only? I think we covered that in our presentation as well. Somebody's going to add something or emphasize?
I think we can emphasize that the use of PPE is based on the outcome of the risk assessment. And I think partly, Bulela, you have answered your question that should it be the case in Department of Facilities treating confirmed or COVID cases. So based on your risk assessment, you have to check the likelihood of cleaners getting exposed to the hazard, and you determine which one will really respond to make sure that the person does not get infected.
If I may add that we spoke about the risk assessment should also include other aspects. So for the cleaners, if they have to cleaning using some of the material that was discussed. They need to have appropriate PPE for those. So let's not confuse that the same PPE that is for protection against COVID is necessarily what they should use for cleaning. To be dependent, look at what they are using to clean. If just for cleaning in general, wherever they clean, they should have the appropriate PPE for cleaning and for those chemicals. But if now it's specific now for COVID, if they are cleaning areas where the aerosol generating procedures are done, remember there are people who are potentially exposed. So in those areas, it's going to be appropriate PPE recommended for that area. But also before I close now, if they have to go and move from that area to another area where it's not a high-risk area, where no procedures are conducted, then there's no need for them to take the same PPE that they used in another area or the same standard to use in an area which is not classified as high risk. So the long and the short of it is risk assessment. Look at your activities and
Critical. The next question, I think, by the same Bulela is, so less than 7% alcohol will not be effective. This is the question of sanitizing. And my sense is hand sanitizer in particular, as opposed to surface cleaning.
So the recommendation is any alcohol percentage of 60 and above. So it should be effective.
Thank you. So we have a question from Kamal Kumar. You want to add something? You okay?
No, thanks.
Okay. Is it scientifically proven that people are not infectious during the incubation period? Is it scientifically proven that people? Okay, that's a recognition. Can someone who is COVID-19 positive infect someone else even if they are asymptomatic?
I think that's a good question, and from what the literature has shown so far is that the majority of cases, people are more infectious when they're coughing and when they're sneezing, when they're symptomatic. There have been cases reported of asymptomatic people who have been infecting other people, but that doesn't seem the norm. The majority of cases seem to be around people who are symptomatic spreading.
Okay. The next question is, can someone who is COVID-19 positive infect someone else even if that's a condition? Right, so we move to the next one. Question asked in relation to the fact that one of the preventive measures is that we need to wipe surfaces often, and I assume that this can be extended to our floors as well. So the question of cleaning of all surfaces within the dental and general practitioner environments.
Yes, it must be frequent, especially during procedures where you get spills, where you get blood fluids or any other fluids on the floor. That's where it should be cleaned first and disinfected afterwards. So like I said, depending on your activities, you will judge during when to disinfect, when to clean. But it must be as frequent as possible.
Okay. If everyone is not tested, can the stats you present be of any significant worth? If there are 10 unconfirmed cases for every confirmed case, it changes stats by a whole decimal. That would be corrected mathematically, but my sense is, could we just get a sense? So sometimes we won't have accurate stats because not everybody's been tested, and we won't have accurate stats because test results have not yet been available. Would that be the case?
I think so. I think we've got very strict criteria with regards to testing at the moment. And, if you compare ourselves to other countries, we're not testing as much. And it could reflect a bias in our, in the stats that are out there.
But the stats we have are alarming enough for us to ensure that our GP and dentist practices are safe and healthy environments for both ourselves as practitioners as well as our patients. I think more importantly, I think the point raised by Odette a moment ago is that as a country we must consider our resources and see if we can improve on either the potential maximum use of PPE or the potential maximum testing capacity. But that's what we have at the moment, and we need to ensure that the stats we have is an indicator of what's happening. The next question: do you have any recommendations for what dentists can do to prevent spread and to screen the possible positive patients and contacts we use a screening form, but some patients may not be honest because they are in pain and want treatment. Interesting question.
That is definitely, you know, we require the person's complete honesty in order to make appropriate decisions of whether or not, you know, we should let somebody into our practices. And I'm just not sure how we combat that, because there is nowadays a stigma even associated with people not wanting to, you know, be known to be positive. So it is definitely a challenge. I'm not quite sure how we address it, but I recognize the challenge.
So a question, as let's assume I'm part of an audience, is it perhaps then not best practice or to err on the side of treating all my patients as potentially positive, and therefore put in place the necessary, you know, measures to ensure that both the patient is protected from me as the practitioner, and as practitioner and staff, we are protected from an assumed potential positive case.
That's
Also, I think it also helps to let people know why we're asking for that information. Because as it is, when we screen people, it's looked as if it's more for punitive measures than if you whatever, and people view that as being punitive. Whereas if you communicate that, because this will help your doctor, you know, and this will help with assessment and so forth, that it's not necessarily punitive, but if you disclose, you know, it's going to even help your doctor to be able to help you better. You know, they can maybe even advise of how you could be and whatsoever.
And as GPs and dentists, you can refer patients, and that would be an advantage. But also the process you put in place for screening should not make it obvious, you know, what the information that is being provided. So the staff needs to ensure that when your forms or the screening tools are being applied, that this is a sort of, you know, scanned in a way, and communication with that particular patient is done very confidentially, privately. Unless you're going to, you know, ask me questions in front of everybody else, I'm probably going to tell the next patient not to give you any information. So let us make sure that the processes we put in place is going to garner the confidence of our patients and ensure the confidentiality. The next question is, do we have, okay, well, I'm not sure this is a question. I think we have 195 patients in hospital, 65 in ICU. That would be the numbers in 50% hospitalization and 5% physical care work out. Thanks. Okay, well, that's about sharing information. Probably based on a particular presentation, and we can't make the link now. We will ask our panelists to relook at your comment once this particular session is done. So the next question is, how is the critical shortage of masks, gloves, and sanitizer being addressed? Do we know as the NIOH?
I share the frustration maybe from people who are in need of this equipment and they don't, or they can't find places where to buy. I mean, in the past few weeks, I was also checking with suppliers, and they do order, but they're not coping with the demand. So the supply in relation to the demand is not working. And that's why we are emphasizing that if all organizations can try to do risk assessment and give PPE to those who need them, then perhaps it can help. I don't have the specific answer, but my sense is whatever stock that is, whichever organization or the supplier, whenever they get stock, they already a lot of requests from different organizations in their actual.
And I think it's important to just remind you, many of the colleagues on the panel here has emphasized your own risk assessment. And to tell you sort of in advance, on Thursday, we are going to have another Zoom session starting approximately at 11 o'clock on risk assessment itself. So we are going to definitely send this invitation to all of you that's given your contact details. The next question deals with how do we obtain the flu vaccine? Assuming that the stock is enough, because I got the sense that given our COVID-19 environment, the health workers have been prioritized for the application of flu vaccine.
Yes. There has been prioritization from the Department of Health for healthcare workers. But it's similar to what Gina said with regards to the PPE. There's such a demand at the moment. People have, been listening to media broadcasts about, the benefits of taking the flu vaccine at this time, and they are very limited.
My recommendation would be that your dental and GP associations, through your organized bodies, you do formal representations to the Department of Health and express your need and engage directly in order to determine how the members of your associations and bodies their needs can be addressed. Our next question deals with clarifying if clinicians or medical practitioners are to follow the guidelines strictly with regard to testing. Is there a shortage of, is that the regions of testing? I'm not sure if that's reagents. Thank you, Annika, of testing capacity at the moment. So I'm not sure if I'm putting that to Annika or someone else.
Okay, when it comes to the guidelines for testing, the NICD has requested that every doctor, before you actually collect a specimen, you discuss with them. Mainly for the reasons of there has to, like we said, you cannot just test, anyone for the sake of confirming or not confirming, just a clearance test. But there have to be specific symptoms, and somebody on the other side needs to be sure that there is really an indication for the testing. So for that, it's not really an NIOH specific or workplace specific, but I would really recommend, for the benefit of dealing with this pandemic, that we really adhere to those guidelines, calling NICD before you collect a specimen, and just to be sure that the clinical presentation is in line or justify collection of the specimen. But the other issue is that what we know is that some specimens have been collected, but they haven't been able to test, because sometimes they'll say there's not so much that was collected. So that's why it's very important that somebody discusses with you that you can collect the specimen, make sure there's enough, and so forth. So because this is new to all of us, I think it's better to all respond to it in a coordinated manner and make sure that you contact someone at the NICD so that there's also a follow-through of what specimen you have been sent and so forth.
Well, it's clear that all our policies, guidelines, and protocols, although striving for the ideal, have been tempered by the constraints of our resources. And I think we've just had a very practical guidance with regard to testing.
I just wanted to add to what Mpumi said. I completely agree, and the truth is that the NICD are the people who deal with this directly. But I know there has been a drive to do more testings. And also, just to stress on what Mpumi said, that it's very important in terms of when a assessment is being done, that the appropriate information is it's labeled appropriately, all the details, the phone number of the person, all those details are filled in on the form so that contact tracing can happen, so that all these public health interventions can follow through.
Annika?
Okay, just to add to what I said, all the information and the relevant forms for testing and sample collection and so on are on the NICD website under COVID-19 toolkit.
Thank you very much. And there is another indication of a key resource for you. The question from Tumani is, PPE in the dental practice or private practice, must you change it after seeing each and every emergency patient? So after doing, for example, an extraction?
I think this one we would like us to address the issue of once-off use or reusing. So again, it depends on your process that you're going to do. Remember, if your process will result in contaminating your PPE, you may transfer that contamination. Your PPE can become a source of infection when you deal with the next person. Alternatively, when you contaminated your PPE and with COVID, with droplet infection, and you touch your eyes and mouth and so forth, you can contaminate, you can be a source of infection from your PPE. And that it depends on your risk assessment, that how should you use your PPE in relation to those activities. And if it informs that with this one specific one, it's a once-off only, use only, it has to be like that, unfortunately. And I do understand that we're talking about shortages of stock. But if you reuse and again you put yourself in danger and defeat the whole purpose of using the PPE properly. There are other means where you can decontaminate or disinfect, but I know that some guidelines are talking about having maybe different sets of PPE. As you contaminate others, you decontaminate or disinfect others, you can use the other set and so forth. So it's something that you need to develop your own standard procedures within your practice.
And critical, it's a conversation that you must have within your dental and GP associations. You need to set a standard on how to address that. We can give you the broad general occupational health guidelines, occupational hygiene guidelines, but specific risk assessment and specific, occupation-specific discussions is critical. Okay, the next question, I would like to know the procedure regarding leave for employees who were either self-isolated or in quarantine. Which leave do they apply for and through who? We do have a resource with regard to that. We're not going to engage in answering that question in our panel now, but we will share that information with you. This, in fact, was a whole Zoom session for almost 2 hours, I think, with a panel of both a lawyer, a member of SASOM, the Department of Labour's inspection, as well as compensation fund sections. We will share that with you. The next question, are you going to address the almost total absence of availability of PPE? I think it's come up in many of our replies, and again, I think it's important for you to, in an organized way, engage with the Department of Health and other authorities in order to ensure, and through your professional bodies, Health Professional Council, Africa, etc., in order to have a sort of global solution for that. Lastly, with regard to specimens, does one need for the COVID negative? Can someone just interpret that?
Do I need to be COVID negative?
I'm assuming that this comes up with regards to when does a person return to work. And we were just looking, and I think we showed the CDC guidelines, which may or may not be relevant in our setting, which either gives you a test-based approach where a person has to have a negative test, 2 negative tests at least 24 hours apart, after their symptoms have, a period of time after their symptoms have stopped. This, they may be pushing for it more for health workers, but in terms of feasibility for the general population, when a person is negative, currently the recommendation is people have to be symptomatic. So post-recovery, in terms of our strict guidelines, it may be difficult to get the testing done, with the criteria of not being symptomatic. So it's a tricky one. Those are just the guidelines, and mostly it's American-based CDC guidelines of a return to work. But I think that we need to be a little bit more flexible in our setting and maybe need to use the more symptom-based guidelines, or, we return to work after a period of not being symptomatic for 7 days, or one of those may be more appropriate in our setting, given that we may need the test for people who are symptomatic.
And as the company said, please contact the NICT. I think that's going to be your most important guide from a local perspective. I'm sure you agree. Okay, so the next question is, do we have to administer the flu vaccine to our employees in our practices, or do they have to pay for it, or do it somewhere else? What will be the recommendation? Assuming that our GPs and dentists can access the flu vaccine, what are our recommendations?
There's no have. There's nothing like you have to administer it yourself. maybe didn't come out clearly from the presentation. The issue was it's a recommendation. It's more of a clinical recommendation. So ideally, any person you can recommend to employees that you can or inform employees that it's recommended that they have flu vaccine. However, if maybe the doctor feels they've got stock of flu vaccine and they can easily sort of share with their staff members, this is something that can be discussed in-house. But it differs on different platforms where maybe people have been seeing their own doctor, that continues as such. But it's not a matter of you as a doctor. You have to actually even get to the extent of administering. Then it sort of defeats the purpose of the doctor, patient, and the employer-employee relationship.
Okay. And if you're part of a bigger institution or facility or hospital, that might perhaps be easier to address there with the help of the management. The next question is, can we concentrate on, okay, well, this is the question related probably to some of the general statements in our PowerPoint presentations, and we will definitely address where those general statements are not specific to GPs and dentists. The next question, Symptomatic, thank you. So where do we get the high efficiency air filters? Assuming that GPs and dentists might have some sort of probably air conditioning ventilation system, depending on the nature of the building and so on.
I think if they are talking about mechanically ventilated buildings, I think they don't need to go far. They need to talk to people who are maintaining the building. And among those, there will be ventilation engineers or facility managers. I think I'm addressing that one and the next one and the third one. So you need to really talk to them, because with the new risk assessment, you need to involve them, because the risk assessment is done by a different expert. And if you are saying that now there's corona, then now we need to improve even the air supply need to change, the air change, it needs to be discussed with those people who are in charge of the ventilation system. So it's not looking for another service provider here. It's those people who are looking after the building where you are occupying. But if there is no one, my understanding is there is a contractor who comes often to come and service the ventilation system. Those are the people who need to make necessary changes and taking into account the new hazard.
And then you've covered the question, who can we contact to assist the negative pressure ventilation? And then the next question that's also covered, and that's again from Kamal Kumar, can you please tell us where we can purchase the specialized negative pressure ventilation devices? Okay, so let's move to the next question from Dr. Pinheiro. What equipment do I need to install in my dental surgery to prevent viral overload should a patient be positive?
I'm assuming you're saying when the patient is there and the patient is positive and maybe you get to know afterwards. I'm not sure.
Maybe,
Yes.
I think maybe they are thinking maybe when someone is sneezing or coughing, there may be accumulation of those droplets, particularly in the room. So if the room is ventilated enough, that can help with the dilution. Then if it's mechanically ventilated, you need sufficient or good ventilation. That's how I think. I'm thinking of the build-up of contaminants.
And all of it is a comprehensive group of preventive measures. And so in terms of your risk assessment, you'll have to continue with the other measures of ensuring that the droplets are not as contained, the hierarchy of containment, including all surfaces cleaned. I think all of that goes together with what we've just mentioned. You need to explain that dirty hand towels and lack of soap in the patient toilet must be replaced by fill-away paper towels. Well, that would be a big concern if your practices still have this in place. It would mean that you have not undertaken your risk assessment and you're not guided by the adjustments that we have just encouraged a moment ago. The next question is, required PPE obtainable for private practice, what constitutes minimum protection? prevention. We continue working after contact with a COVID-19 patient who in private practice are affected by lack of PPE. So if there's been a COVID positive patient, clearly the patient needs to be referred, and the process will be followed in order to contact the NICT, all these forms to be completed. But from sort of a health and safety point of view for the practice, what would be essential? Would it be essential just to do a complete clean up of the premises, complete sort of, I don't know, for lack of a better word, decontamination?
I think it's important, and I think that's why it's so important to isolate people to specific areas, so you don't need to decontaminate the whole practice. You would be where that person was localized. In terms of, at that point, I think you would need to remove your PPE in the appropriate fashion and discard it, and in that situation, put on a new PPE within a known positive patient. I don't think that you want to take that risk.
And also by that time, if there had been a COVID positive patient or visitor, all those who may have had contact with that person would therefore be a person under investigation, is the correct term.
If the risk was high risk,
Yes.
and the appropriate behavior was not chosen.
We have reached the sort of 1 o'clock mark, which we targeted for our session. I'm not sure if we should just pause the questions there and then allow our panelists to look at these questions. We tend to include the questions in our frequently asked FAQ section, and there's probably going to be a GP and dental group of questions that's specific for your needs. At this point, I need to thank everybody in the room from the National Institute of Occupational Health, my colleagues, and also particularly you. Up to 500 connections today, and we've reached the maximum that we can accommodate on this particular Zoom license. I want to say thank you. For those who have not yet added your contact details to the chat bubble at the bottom, for you to receive the presentations, and as we manage to answer all the FAQs, to get those questions out to you as well. I want to say thank you very much to all of my colleagues, and we will have the risk assessment session on Thursday at 11. So on Thursday, the 2nd of April, please, you will receive via your communications, that's via email, the link to that Zoom session, and we hope to see you on the risk assessment session. Our colleagues have been pointing to you the importance of doing the COVID-19 required 1 hour. If you've not done that, this session is going to be critical. Thank you very much.